Good evening, everyone. Thank you for joining us again to another presentation of the Department of Periodontics Chairs Lecture Series. And welcome to the new schedule that we have now from 6 to 8 p.m. We're doing this so that people have time to go back home, get in front of their computers, maybe grab something to eat before we start with the lectures. So tonight I have the great pleasure to introduce a great friend of mine, Dr. Elchar, who completed his doctorate in dental surgery, his postgraduate education in periodontics and dental implants, and his master's in oral biology from the New York University. He is a diplomate of the American Board of Periodontology and Implant Dentistry. He's also a fellow of the ITI, and he serves on the education committee of the American Academy of Periodontology and the Academy of Osseointegration. Dr. Elchar, currently he serves as clinical associate professor in the Department of Periodontics and Implant Dentistry, and he's also the director of Advanced Education Program in Periodontics at NYU. He's also the former director and founder of the Advanced Education Program in Periodontics at the Lutheran Medical Center. He has a thriving private practice in New York City that specializes in dental implants and periodontal disease. And he's also the founder of the EEC Institute, which is a continuing education and research institution that focuses on the advancement of clinical periodontics and implant dentistry. Dr. Elchar always delivers fantastic lectures. It's a great pleasure to have you with us tonight. Thank you for sharing your time with us, and welcome to the Chairs Lecture Series. Thank you, Ed.
Thank you, Rodrigo. It's going to take a couple of minutes to say some thanks to a lot of people that I know at UPenn. Rodrigo, I'm very happy that you came to UPenn, and you are a very dear friend, and I wish you all the luck, and I hear good stuff. And also, I had a very fun relationship with UPenn since we do the Tri-School, which is that series between UPenn, NYU, and BU. But the most important thing is I was a student when I shared this thing in it, and I had all the pleasure to have all the tenors that you guys had, Dr. Amsterdam and Weisgold, and so it was always an honor to be going there and also to be part of it. And also on top of it, you took a very dear friend of ours, you become your dean, Dr. Wolf. It's a very close friend to us, and we have a lot of fun memories about him. And we are happy that he is with you guys. So at the beginning, I have to do this disclosure. So I don't have any off-label or research things. So I'm going to share with you my clinical experience with it. So I do come to you from NYU. NYU has been my home for 27 years. I came for NYU for 1 year, and here I am 27 years. It's a very interesting place. Usually we say how many people we see. Nowadays we are limited to a few people, but in a normal life we see 300,000 patients a year, and we have over 1,500 students. So it's a very big place happening, and I'm very proud that I had this experience to be in it. And as you said it, I am as NYU as it gets. With that said, we have a new addition that we have, and we are very proud of it. This is where we do the didactic, and we were going to host you for Tri-School this year in it. Nevertheless, this is on the graduation time. We get Empire State Building to turn purple, and unfortunately this year they didn't have a chance to really enjoy the graduation the normal way, but hopefully we will get stronger out of this experience. But the most important thing in my career is this wonderful young men and women, and this is a picture taken at UPenn last year, so I couldn't pick better than this one. And we look forward for next year. I don't know how we're going to work it out, but we will definitely look forward for it. And I do have my private practice, and this is something that I cherish a lot. With that said, I want to start talking to you about the lecture of today, about the current concept. But before we start that, it's always nice to remember or go back of what we have or what do we have in dentistry. And still for years, the driving factors in dentistry were always limited or hovering around implant dentistry, aesthetic dentistry, and oral health. But the interesting part is to do that and to do a very successful implants, we need to place the implant in the most ideal position, or what we call it the prosthetically driven. And to do that, we need to have a successful ridge augmentation or successful socket preservation. But all of that context is important to lead to a peri-implant health. Without peri-implant health, we can either end up with peri-implantitis or a wrong treatment planning leading to complications. So this is what it is so important. And this is why I want to move on with this and talk about the status of dentistry today. With the opening of a lot of people doing implants, and I'm not here to judge either way, so you can see that there has been a tremendous increase of complications. And this is the first case I ever encountered. I was freshly out of the program. I had the first position in continuing dental education at NYU. And there was over 1,000 cases with peri-implantitis. That you have to put yourself back in 1997. The term peri-implantitis was not common. And this is a hydroxyapatite. And back when I was trained was only one implant and was pure titanium. And we never encountered peri-implantitis. So this is how I started my journey from 1997. And it continued with me till now. Not something that I'm proud of, but this is how it is. And you can see it always new stuff keep coming up. This is a young lady, 24-year-old, Australian, moved to New York to do architecture studies. And while she was here, she had to have her number 9 replaced by an implant. As you can see, there was a big aesthetic failure in that case. So when we look carefully, it is from the positioning and the treatment planning. And this is something common we are seeing over and over and does not stop. And when you look at the scan, I mean, the operator followed whatever the bone is. So they placed the bone, but not within a prosthetically driven manner. And it led to this aesthetic failure. Or this lady became good friends together, and then you see this implant that they placed on her. And every time I look at it, it amazes me what they were smoking when they placed that implant. Because this is the implant that you want it to fail, it never fails. And you can see that not only they placed it in the wrong position and up high, but also encroaching on number 7. That took us almost 4 years to fix. Leading to this young lady, a 37-year-old female, that when she was in her early 20s, she had those 2 centrals replaced by implants. But once we dig deeper, we can see that there is a periodontal condition here. It went unchecked and led to the exfoliation of this implant. But with it, it mutilated the whole bone. And when you look at the CBCT, you can see the amount of damage that she have encountered. And literally, you can see at the bottom here, the amount of bone loss. So she had what we used to call juvenile on my time, then aggressive, or this pattern of incisors and motor, as we call it today. And when we look in oral DNA, she was scoring extremely high in the red complex. Again, this is what the workshop has shown now, that peri-implant periodontitis, if it's not under control, will lead to peri-implantitis. And the damage of peri-implantitis can be devastating. And another example, an immediate implant that I placed and I never seen the patient, and within 4 years, you can see 2 days before my birthday, they send it back to me, and you can see the amount of pus and infection. When you go deeper, when you lift, this is a complete mutilation. You have a complete U shape of a defect. So this is really what we are seeing in real life. So what I wanted to discuss with you, these 4 points, and I want to start by revisiting the principles of bone regeneration. And when we talk about the principles of bone regeneration, one has to start with the cardinal points of bone wound healing. And when we look at it, it all starts with the blood clot formation, all the way to formation of granulation tissue, and from there to the woven, and from the woven to well-organized trabecular and cortical bone. So if we go back to what we did and how we learned guided bone regeneration, one has to go back to history in 1994. This is really the fundamental study that was done in Switzerland by the group from Bern, by Professor Schenk and Buser and the group. And here what they did on Legal Dog, they created a U-shaped defect and they put a membrane and they stabilized them with screws, and they filled in the gap with blood. And when you look at the histology at 2 months, and we look at the radiograph, you can see that the bone is coming from the walls. And if you look at the histology, this is at that time, they didn't know what to call it, the immature bone. What we know now, it's the woven bone. But when we look at their study, it was stopped at 4 months. And you can see at 4 months, the bridging from wall to wall, and not, most importantly, in the histology, the bridging that is not complete for the trabeculation. And that's how we went to 6 months time of wait that we do it on when we do a guided bone regeneration. So, and the interesting also part is the spaces that collapsed, the space were not maintained, they ended up with no bone regeneration, which led them to postulate to achieve a successful bone regeneration. You need a space creation, a space stabilization, and space maintenance. And this has been confirmed over and over by other authors. But I wanted to go back to the original one. And from there, let me run with you a case, and it will really show you exactly how it works, exactly how they showed it, but in a human. In 2000, I had this case that was referred to me. An immediate implant was placed in position number 8 next to a number 7 that had an endodontic failure. So imagine what happened if the whole thing blew up and she ended up with a U-shape, exactly the experiment of Schenck. And when we look at it at that time, you have to look back in time, and we had only the autogenous bone at that time, but it did improve from when I trained in early 90s to when we did that case. So we used the piezo. We took that block, and you can see the marrow that came with it, which makes it a osteogenic source at this point. And we filled in the gap with a xeno, and we put the membrane. And let's follow it radiographically. If you go from time 0, you see the lines of the block with the host bone. And we look back in 1 month, you can start seeing the resorption at the inside and the apposition that is coming from the sides. And moving along to 3 months, you can see also how the bone is coming from the borders to the center that is more resorbing. And then in 1 year, you can have a complete merger from one side to another. And definitely with the cortical bone, you can see always this resorption on the head of the screw. Now, it varied. If you look at the people who did a lot of blocks, they can tell you take a block from the retromolar area versus from the mental. It is a huge difference in resorption. So when we look at it clinically, we did that. That was a theory from NYU to place one implant and make a cantilever, something that I don't do anymore. And that's because it creates more of a host for plaque, and it's going to be difficult to maintain. But this is a 20-year follow-up on this case. And when we look at it radiographically, it's pretty stable. So definitely we know that autogenous bone work, and definitely we know that if you follow the structure of the guidance of bone regeneration, we do end up with a buildup of the bone. Moving along in that, let's review the grafting material. So where we are today and what we did over the years. So this is the map of all the grafts available. And that always, when I look at it, it takes me back in time in early 90s when I was training. We only had one implant, one membrane, and one bone graft. And every time we did the case, we did the second stage. One hand was on the screwdriver, and one hand on our heart. The implant comes out in our hand or not, because if it doesn't, then it's guaranteed it's going to work. But this is how we were, and look where we are today. And you need really a good understanding of all these graft options that we have. So let's start with the xenograft, and in particular the bovine, because that's when it started, mid-90s to late 90s, and was really the holy water that came, because it changed all the grafting at this time. So let me share with you this case. This is a case that I inherited in my practice from a gentleman that retired in my office, and he used to love xenograft. And when I went to place an implant in that position, being trained at NYU, we've been trained so much in histology, I couldn't resist and taking a core, and I submitted to histology. So this is a 10-year later. If you look at it on a higher magnification, you can see we have the blocks of xeno that's still there, a good deposition of bone, still remodeling, but inside Nothing changes. The lacuna are empty, good lines all around them, but the xeno is still there. So another case that I did in May of 2000, a patient that was referred to me at this point, at this time, and she stayed with me all these years. And you can see I had to do a root amputation, and I grafted that socket with the xeno. And you can still see the xeno at 18 years later here. And when I did the extraction, I have a very good relationship with her. I asked her if she allows me to take a trephine of that area, and she did. And that's the result. This is an 18 years later. You can see a good bone remodeling. You can see the line of deposition, the lacuna, the vitality, the movement, but inside the xeno is still there. It never changes and it stays there. So this is in regard to the xenograft. What about the alloplast? In particular, collagen with ceramics. That's a study that I've done and I published in 2016. So if we look at it in Europe, they do only xeno and alloplast. So that was really tailored to that market. And when we did this case, it's a series of of sockets. We took the tooth out, we debrided the socket, we put that collagen with ceramics, covered it with a resorbable membrane, achieved primary closure, and then we took a CBCT at 6 months, and then at the time of the placement, I trephined it. It looks great, sounds like bone, it feels like bone, but is it bone? And nothing will tell you other than having a good histology. And this is at the time of the placement. In a radiograph, you can see, like in the xeno, you can see that cloud of white color. Now, when you look at a histology, here it's actually, you can see a good trabeculation all around, but still where the ceramic inside, it's still changing, it's still deposing. And you can see that there's a good activity, but it's taking its time. So it's slower than xeno, but it reacts the same way. And this is a follow-up of 6 years. And you can still see the line where the cloud of that alloplast is inside. Literally the same thing we see on a xenograft. Now, the question is there any risk with using all of these, alloplast or xenograft? Well, there is a study that came in 2017. It's a report, actually. And it's a very interesting report because I experienced it both in our clinic at NYU and in my private practice. And let me share with you what we've noticed. This is a case at NYU. We had this sinus was done 100% xeno, and the patient came a few years later with this infection. Now, the whole implant came out with it, the xenograft, exactly how this article was reporting. And all it started because of peri-implantitis with an excess cement that was left behind. So the bottom line is when you get an infection, which is an inflammation, basically the bone resorbs all around that ceramic because it becomes a ceramic and it becomes a ground for more infections. And moving along is another case. Also, you can see here the neck of the implant is bathing in cement. That led to a peri-implantitis, and which inside the xeno, it exploded drastically. And this is in my office, and you can see this is recently after the pandemic. She was having an infection. She came, and sure enough, when you remove it, you can see this is the xeno, and that's exactly what I was trying to say, that the bone resorbs all around it, and then you are left with that synthetic material at this point. So this is something to keep in mind. Moving along to allograft, and my experience with allograft been since the early 2000s, and let me talk to you in particular about the putty, since I published that paper back in 2013. And in it, we did the same thing as I showed you before with the collagen ceramics. I extracted the tooth, put the DBM. This is a DBM with chips, meaning more cortical in it. And at the 6 months time, we opened the site. And here, because there was the ridge, so I didn't want to biasing my results, I took 2 cores from the mesial and the distal. When we look at the histology here and we go on a higher magnification, one can immediately admire the nice bone. And yes, there is some residual graft, but look at the activity that is happening. And this is within 6 months compared to the other ones. So this is it tells you immediately that you have a good bone, a uniform bone, and a vital bone. And this is the result. We had a 44.6% within that frame time of 6 months. So the question is the growth factors. And the growth factors, we talk a lot about them. What is really a growth factor? It's not the time to talk about that, but I was really involved with the recombined human BMP2. And I also served on the board of advisory for Medtronic. They had a product, but unfortunately, the FDA demanded too much from them, and then they dropped it. It was a GDF5. And this is also from the family of the BMPs. And also I had the luxury to work also with the Puros. They were having a supercharged product, but again, because of the FDA went through a rough, rigid regulation from '09 till not long ago, and then it loosened it up, and now it's becoming back to having good products. So my experience with the BMP2 was extensive, and I'm going to share with you one case, and this is where we had an endo done, and then it didn't work out, so they sent it to me as an emergency, and you can see the infection. So when I removed those two teeth, and this is in 2010, December 2010, you can see this is a big defect in the mandibular anterior. And at that time, I was doing a proof of principle where we used recombined human BMP2 100% under a titanium mesh. It was me and it was Craig Mish that he published at the end. I didn't get a chance to do that. And we use 100% under the membrane, the titanium mesh. And let me share with you how things have evolved. This is the primary closure, the healing. And then if we look at the 1 month and 4 months, it's exactly how we saw with Schenk. The bone is coming from the sides. So the walls are extremely important. That's something that we know and we are very aware of it. And this is a good example of how the growth factor instigate the wound to fill in and lead you to bone. So at 6 months, I took a cone beam. And when you look at it, this is what you see usually with a recombined human BMP2. The color density is less because also dependent on the age of the patient. So the older they are, the less dense the bone is. And this is one thing that we noticed in our case series that we were collecting. And we removed the titanium mesh. You can see it's a great bone. And we placed 2 3.3s at that point. And this is 9 years later. And you can see that the bone is still very well dense in here. But nevertheless, you can see some crest to bone loss. And this is very common with 100% recombined human BMP2 because it's always active. It doesn't stop. So I moved and I started adding more cortical bone and started to change a bit in my direction with the use. And this is another case that a referrer has extracted number 14 and sent me for 13, and there was a fracture in 13. So when I took them out and I waited for them to heal, and then I opened it, you can see the amount of destruction on 14. And also when you take 13, you have also a dehiscence on the buccal. So I combined the DBM and I added more cortical because I was looking at the density of bone. And then I placed it, molded into place, and then I added my recombined human BMP2 on top of it. And I stretched the tissue, which we will talk about it in few, and I let it heal. And this is the time I was really starting to do guided surgery back in the early 2000s. 2010, Stroman came up with the Gonix table. I don't know if anybody with the audience would remember that. It's just something you can mill, you can get the coordinate, and I will show you, and you will talk later on about the digital in it, how it changed drastically. So we know that we build the bone, we were short from the sinus, so we combined the placement of implant with the crestal sinus elevation. And this is what the Gonix table allowed us to do, a guide from a coordinate with models. But the problem is once you cast a model, you pour it and stuff, there's always variation. And that's what it was non-accurate, and it died away until now we have the STL files, and we will talk about that at the end. So we put the guide and we open the flap, and this is the bone, and we place the two implants as we planned it. And I did my little rotated pedicle here to close the gap in between. And this is the buccal. And we had a good 2 millimeter or 3 millimeter of band of keratinized tissue. And you will see why I'm saying that. And this is just to illustrate for you my way. I take a small pedicle of tissue and I plug it in between. I wrote that's part of a chapter that two chapters that I wrote in that book. And this is the reason. This is 10 years. And you know, the older we get, in practice, you can see, start appreciating, looking back at your cases. So she came to me after a long time. I've never seen the result at the end. She came for another problem, and I immediately took my camera and I took the picture on particular like this, just to show you the importance of having a recall between a periodontist and a referral, because you can help them control the plaque. And this is hopefully a message that can be resonate. And you can see here also with time the fatigue of the ceramics, and as well as the soft tissue, how it did shrink with time from 3 millimeter to what we had at this point. But nevertheless, when you look at the X-ray, you can see the nice density of the bone around those implants, because I did an addition of cortical bone along with the recombined human BMP2. So one day I had this lovely lady, 83 years old when she came, and she's been under my care for a long time. Unfortunately, she was walking on the sidewalk of New York, and she fell, and she really fractured number 7 and 8. It's sad, but it did happen. And when you look at the scan, you can see the impact on the crown, flipped the roots and broke the buccal plate. And, you know, she, being at her age, as I said, well, why don't you do a fix? She said, no, I want to have an implant. So I said, God bless you, we will do that. So we extracted the teeth, and you can see here the amount of fracture. So the whole buccal plate was gone. We removed it, and you have a box. It was an emergency. I didn't have a combined human BMP2. So at this time I used the titanium mesh, and I put 100% allograft, the combination cancellous cortical. And here, I love this case, but unfortunately, for the first time, I allowed somebody else to take a picture with my referral, and that's an advice. Don't ever let anybody take your pictures. And I did a primary closure, and then I took immediately a scan. This is something I do systematically to see how I placed my bone graft, and then at 6 months. And we went for the surgery, and then you can see the amount, this is the soft tissue healing, and then in the surgery you can see the bone, and I placed the 2 implants. And I have this, for me, I always tell my students, there's never enough bone. I like to add more. I added cortical bone and covered it with a membrane, and I closed it up. And then I did my second stage, also using my technique of rotating a pedicle to cover in between. And this is literally, she came last week. I said, let me take a picture for the purpose of your of the lecture. And this is a follow-up of literally 10 years on that case, if not less. So we published this paper on titanium mesh with 100% allograft, along with my students, partly from my office and partly from NYU. And we've had a successful results in bone augmentation, both horizontally and vertically. The differences here is one with a printed model and one from a plaster model. And I'm going to talk later on about the printed models. So for us as a clinician, we have a bifurcation. So are we going to still conforming on what we had in the 90s? And by that, meaning stay the same way and use only alloplastic xenograft and autogenous bone, or decide to move forward and choose to transform and move into allograft, and in particular mineralized bone. And this is something that I've been living with it, and I'm a big proponent on it. And there's a lot of studies. One study came from NYU by Froome, when they compared in sinus the xeno 100% versus an allograft, and they had double the vitality of bone and less residual material. Going also to a very dear friend, Beckley, and he did it for a cleft, and he found an amazing amount of results. So he's saying that it avoids us from doing an iliac bone. And to not long ago, Nevins published in the Sinus is a cortical cancellous 50-50 and good vitality and new bone formation. But I always look at the medical literature. And when you look at the literature in the medical, especially in trauma and derm, you can learn a lot in orthopedics. And you can see what they did. They used cortical, the allograft. They compared a cortical versus a cancellous under pressure. And you can see how the cortical preserves its density and volume versus the cancellous that resorbs, but you can see the difference in vascularization. So that will lead us to, if we can combine cortical and cancellous, we can control the biology and the wound healing. And sure enough, I'm going to illustrate it for you in 2 cases. And this is a fractured canine. And you can see now there's no bone, and we took it out. And at this time, I followed my roadmap of socket classification. This goes to grade 3, which is the ridge augmentation. And from there, I placed my implant immediately, well confined within the bone, following Joseph Kahn recommendation. And then I layered my bone. Now, there's a lot of terminology, sandwiching, and all of this stuff. I like to call it layering because I put a cancellous layer first in contact with the bone and the implant, and I layered the cortical bone. And you can see Buser, when he lectures, he talks about the bovine bone, but you don't need bovine bone. You have the cortical bone. You have the luxury of combining cancellous and cortical bone and achieve the volume and achieve a less residual bone and a better vitality of cells. And then definitely place the membrane and stabilize it, achieve primary closure, passivating the flap. And then this is at 6 months. You can see not only you have bone that is really vital, look at the vascularization inside of it. That was another proof of principle in the combination of cortical cancellous. And this is a case of a 10-year follow-up. And this is when they came up with the BL at Stroman. So you can see the good success with a allograft. Even moving it further and pushing the envelope with it. This is a central that was fractured and on a very aesthetically demanding case, because you can see he has an average smile, and this is what he's controlling it, but you can see the difference in shape, difference in size. And Dr. Weisgold always used to talk about these things. And you can see that also when you look at it, it is multiple shapes. There's not one shape in that, triangular, square, two triangular. And in this, I call it the grade 3, but you can go into the grade 2 with the rotation of connective tissue. So extraction of the tooth. And this is my old way of doing the connective tissue, the pediculated from the DP Matthews way. And I have modified it. And I measure my width, I measure my thickness, my length. And then I go to the palate, which is a great source of connective tissue, and get a good connective tissue. And I flip it over and close the socket that I have layered inside the allograft and the cancellous, meaning put the cancellous on the walls of the socket, and in the center, a combination, and then cortical on top. And then put a fixed temporization. In this case, you can't do them with a flipper or any removable, and wait for the soft tissue to heal. And then I went back to the Gonix table. I did my guide to do it flapless, obviously. And then we went ahead and I placed the implants, and you can tell how old is the case because of the Loxim that is totally old school, and placed that implant. And then this is at time 0. This is at the time of the delivery of the crown, and you can look at the radiograph. And he moved to Chicago, and recently I got the radiograph sent to me, and this is a 9-year follow-up. Again, 100% allograft, put in a socket without lifting a flap, just using that space that was contained. And this is a follow-up from before the extraction to 9-year follow-up. So this is the modification that we did to the original technique from Khoury, from DP Matthews. And you can see we started from the line angle of the canine. This is the line angle. This is where the best bed of connective tissue. And then I de-epithelize this, and we flip it over, and we secure it onto the buccal, and just to cover the graft. Moving along to the review of flap management. And this is something that it is very dear to my heart, because something that you go to lectures and we look at everybody doing their own way. So I wanted to share with you my way and how I do it. Again, base it on science, not the LCR way versus this other way. So when we look at the flap management, well, we know from Wicked rule that the flap does contract. This is a fact. This is not something that we can argue about it. So the flap does contract, and that's what we call, and we talk about passivation, because there is this retraction that takes place. Now, also the wound is very important to be stabilized. again, the flap needs to be secured and stabilized. So it needs to be passivated and it needs to be stabilized. And also we learned it from back in the days, from Hyatt to Piniprat to recently, talked about the importance of the suturing and keeping everything in place. So we know that we have the wound underneath, that we need to create the space and maintain it. But the most important is the flap. The best management of the flap can lead us to a better way of maintaining things in a better and successful way. So having said that, we move along to the third point, which is the incisions. And Langer, somebody that I really admire here in New York, when he did his revolutionary connective tissue, but he talked about the flap. And the flap of connective tissue is not that different from ridge augmentation. I mean, flaps are flap. How you maintain them, how you manage them, how you reflect them, and how you contain them. So if you look at him and the way he came up with it, and he ended up with a vertical incisions. Now, one has to go back in time and look at the study of Mormon. And we forget that in periodontics, we did the most beautiful things. We did Wilderman in the 60s to Mormon in the 70s. And this is a treasure that we cannot replicate anymore today. But look at it, what he did, Mormon, with an angiograph at the time of the incision. And you can see immediately when you do the vertical incision, the shrinkage of the flap and that necrosis of area that takes place. Now, in 24 hours, things even get worse. So this is the importance, and that's why in my protocol, I don't do a vertical incision. And if I have to, because you can never say never, and if you have to, I leave it to the end instead of starting with it at the beginning. Because now at the end, you have to elevate the flap, passivate the flap. We do the second biggest mistake, which we'll talk about it. We cut into the flap. And that's the destruction of the blood supply. But going back to this, you can see that from Langer in 1985 to 1994, Bruno, that we forgot to talk about him, he also avoided the vertical incisions. But also he did not able to coronally apposition the flap, but he did the butt jointing. So moving to more recently, Zucchelli, and really he did a revolutionary flap, is by doing this papilla sparing and preserving the papilla, and that I call it slicing when I talk to the students, because you are really slicing the outer layer of the papilla, keeping in mind that the papilla is a pyramid that is stabilized over the bone, and this is where it should be sacred. That brings me to the vascularization of the flap. When we look at the histologically, this is from Lindy, you can see this is this ocean of vessels that we have under our soft tissue or within our soft tissue over the bone. When we look at a higher magnification in a crosscut, this is what we call it the supraperiosteum. And in reality, when you take the flap and you cut into it, you are cutting this artery. So imagine you've had done 2 vertical incision or even 1 vertical incision, and then you wanted to passivate the flap by cutting into the flap. You really, lack of better word, you butchered the flap. So there's nothing in it anymore. And even if you passivate it, the first thing that we learned from Wicked Drew, what does it do? It contracts. But when you have more injury in it, it contracts even further. And that's why it is so sacred to preserve the integrity of the flap at the time of the procedure. Well, how can we preserve that? How can we mobilize the flap? Well, we go back to tank 8. I mean, this is the mucogingival line. When we go below the mucogingival line in the territory of alveolar mucosa, this is an ocean of elastic fibers. It makes over 70% of the connective tissue. Versus the keratinized tissue, supramucogingival line, and you can see it's an ocean of what? Of collagen, which is made for purpose. So you can see, and they can look at Nobuto in 1989. He does this beautiful SEM where he showed the mucosa how it is elastic on purpose, because the vessels inside the mucosa are circular and compounded on top of each other. So there is a reason, and that's flap is stretchable, and that's what I wanted to share with you. And we published it. I always take pride to see published with my students, but most importantly, when my student becomes directors, and this is Dr. Falah Abed, he became the director at Baylor. I'm very proud of him. This is a good thing that people are moving along with education. So we take them in two different scenarios, regardless if it is mandibular or a maxilla. My incisions are always the same. So I do an intrasulcular slicing of the papilla. I do my incision more towards the buccal, not at the center. And then I come up to the line angle. Now I did a modification, which you will see later on. I do a line angle here. And then I reflect, and this is, you can see those papillas are not going to be changed. This is going to be exposed, obviously. And then the reflection of the flap. And then this is for the other scenario, for single one, the same story. And I'm consistent even in my connective tissue. It's exactly the same flap. And now the question is the papilla sparing. And this is why, what Zucchelli has talked about, and this is the pyramid, and it's all connected to the bone, and the vessels are still there. So there is no risk to dislodge and to lose the papilla. So the incisions are more towards the buccal. Reflect, you put your bone, and you put the membrane. And I wanted to throw a curveball here, the sausage. And I'm not going to get the chance to talk about the sausage shape. And this is something that bothers me a lot, because we don't have a sausage when we do bone grafting. And if you have a problem with sausages, you have a problem with sausage, because that's not the shape that we want. In the country, when you do sausage, you mean you're rounding things, and you need the opposite than that. So we move forward here, and you can see the stretching. So you take a blunt instrument, you hold it with a plier, you go past the mucogingival line, and you stretch out and coronal. If this is the maxilla, and if you are the mandible, you do the opposite. And then you achieve the closure by passivating and good suturing at the coronal part. So let me share with you a small video about how I do the stretching. And this is how I do it. I pass the mucogingival line. You can use the Buser, or this is an instrument from Europe, actually. And you can stretch the tissue, and then you can do the same. You can see how it's passive and elevated. And you can also go to the lingual part, as it is shown here in a few seconds. And that's definitely, you've seen that with Runda and with Orban and all of these things. But nevertheless, this is what I mean by stretching. So that brings me to my final part of the presentation, is the use of digital technology in surgery. And this is something very dear. I've very been involved in it recently, and it's been the last, I would say, 8 years of my career, very consecrated on the digital technology in the surgery. But let me talk to you about 3 questions that I like. What is digital dentistry? How can digital innovation be used surgically? And lastly, can we achieve a higher and more predictable outcome of our treated cases? So the question is, what is digital dentistry? Digital dentistry today is everything. I mean, from the sensor of a radiograph to the taking pictures, to the CBCT, to the intraoral scan. Not only that, it goes further to 3D printing, to the milling units. This is the world of the digital. But the interesting part is when you look at the PubMed, and this is a year late, but still the same, you can see over 8,000 articles published. And in the reality is, all they talk about is taking an impression, it's an immense world, the digital, and that's what I wanted to share with you. So how can we use it in surgery? So let me share with you a case that I did with my former resident that graduated in 2020. And you have a central number 9 that is fractured, and Amit went ahead and extracted it. And here we had a thick biotype, but we had no buccal plate. So we did exactly, this is the picture of the tooth. And there's 2 things I love about taking pictures of the teeth, because this is I learned from Dr. Weisgold. He's really phenomenal in these things. He talks about this, look at the direction of the root. I mean, really, if you want to replicate that and place an implant, you have to put the implant exactly the same position. Otherwise, you will end up with coming from the buccal. So this is exactly what's important, to look at the dental anatomy. And this is the layering of the allograft. Again, you can see the cancellous all around, a little bit of mixture, and then I pumped the cortical bone 100% on the buccal area, and then we went to the connective tissue. Again, exactly how I mentioned to you, from the line angle, we go and we de-epithelize the bottom, and I flip that connective tissue. And it's a key here that we did not put on the in the article at that time, but I wanted to share with you. It's very important is to stabilize this connective tissue on the sides when you flip it. If you leave it loose, it can be detaching from that blood clot that forms underneath it. So again, this is just to cover. We are not tacking it underneath it. And this is a 6 months later. You can see the amount of excess of tissue, which is not bad. And this is, you can remove it, you laser it. A lot of time it end up like this, but this is because she had a fibrotic or thick biotype to start with. But this is what we see on a combine. So now you can see this good bone. It looks great. This is the fill up of the area. Now, how can we manage it from now on? So we go to the STL, we took the impression, and this is something now it's becoming common. But how can we take advantage of all of that? Well, this is what I wanted to share with you. Other than we know the fact that you can stitch the two together, but we moved it even further than that. So now I can go to that co-diagnostic, which, by the way, it is an unbelievable software. It's expensive, but it's worth every cent of it. Because if you go to this cheap stuff, like, you know, the free stuff, you can never do a lot of things that you want to do. And one of it is the segmentation, which is like in Adobe. You can clean up and remove the scatter, which is very accurate in stitching, because that's the problem. You can see the scatter. With this software, you can divide the roots from the teeth, or you can change the density. And here you have removed all the bone and you end up with a tooth. And from that tooth, I can segment it and can take it out. And I can go export it in STL. I take it, this is number 8. So I can go to a mesh mixer. This is a very common, free, a little bit complicated to use, but if you look at the YouTube, you can learn it very easily. And you can mirror the image. So we take number 8 and we make it number 9. And now why did I do that? Because now I re-imported that. That's very important. I re-imported that as an STL into the co-diagnostic. And now when I go ahead and I put it as an STL into the site where I'm going to put an implant, now I can visualize not only the coronal part with the temporary or that radiograph that we did, but nevertheless, it's more important is how the tooth was initially. And that's exactly how the tooth was. So now I can position my implant the proper way. And knowing, and you guys in your Penn, you are the king of this. You talked about the critical and the subcritical, and you talk about this cone. And now you know exactly where the position is and how I'm going to manage it. Now, this is not only what we can do in digital. Now we do the guide. This is common, classic, nothing. You did not wait for me to come and talk to you about guides. But nevertheless, now we can move it even further. Now we go to another software, and that's what we call the CARES software. This is a prosthetic software. That's not an easy software, but it's really very accurate and really very helpful. So now you can start by delineating your area, and from there you can do a whole process that leads you to a model with an analog. And not only that, you can print even the soft tissue. So you have the model with the lab analog, you have the soft tissue, and this is all synchronized with the co-diagnostic, which is the implant placement. Now you go from there and you have a model, you can put the tooth in it and you can print it. Once you print it with the soft tissue, all you have to do is print the tooth and then connect it to that model. And this is to verify that all the fit is correct. We put the guide on top of it. Now I'm printed the tooth. So you print the tooth, and then from there, all you have to do is connect it, and we followed your criteria, the subcritical and the critical. And now we go back and we do the surgery using the punch, lapless, do the sequence with the key of the system that we are using in here. It's going to be Stroman, and then we place the implant. And this is the accuracy. I want to give you tips here, because we take it for granted. Those lock sims, those points, have to be facing exactly where you are ending the implant. And this is all predetermined by co-diagnostic. Meaning, on the guide, you will have a line here that it's printed inside. So when you put the implant, you have to line the lock sim with it. And that's how we'll allow you to put the temporary. Definitely, we cut the tooth a lot because it has a deep bite, and every time it goes in protrusive, it hit it. So it's not for aesthetic, but just to maintain that soft tissue the way we wanted it. And you can see it is prosthetically driven, coming from the center of the cingulum. And this is a 3 months follow-up, and you can see the well adaptation of everything. So this is a case that just came to my office not long ago, and she had a resorption, and she had to lose the tooth. Now, the challenge in that case is, it's tremendous, obviously, young lady, very scalloped. You don't know if it is thin or thick. You have a resorption, and you have a very limited bone in between with very thin nasal or midline fissure line. And when we look at the scan that they sent to me, you can see vividly the resorption. There's no question about it. So when she smiles, I mean, in the smile analysis, you can see the amount of difficulty in this case. First of all, the long axis of the teeth are completely tilted. She has a deviation of the midline. And also when she smiles, you can see it's a high smile. I mean, this is, you can see she is pulling herself from smiling pig. So when we look at it closely, you can see also the dentistry, what is done on her. So now, before I commit on anything, so I planned it, I combined the two together, and this is important, and then I follow the criteria of Kahn. Now I can accurately measure, and I'm sure this is not news for you, that the thickness of the soft tissue, so I have over 1 millimeter, falls exactly into what Kahn has said. And then on top of it, you can look at the buccal plate that is intact, and not only intact, it's pretty thick. Now, where is the challenge? And this is what I wrote in my classification of the socket, is that apical concavity. And this can be a problem. If it is too concave, and then you cannot place an immediate implant. And that becomes, you have to do a delayed approach. This is exactly what I do with the case that you saw before. And also the other challenge is, you can see the nasopalatine, it's pretty immense, and it's moved because of that asymmetry in her face, is moved more towards the position of number 9. And I did write a paper a long time ago, in 2011, was accepted in 2008, believe it or not, about an immediate implant, and we had a high success with the immediate implant. But how can we do it digitally? Now we have a tooth, we have everything in there. So we take the model to the mesh mixer, and then you can extract the tooth. And the new version of co-diagnostic, you can be doing it immediately on it. You don't have to go to another vendor to do that, which can make life much easier. So now you can do that, and then re-import it, and you place it over. And now you plan it. You plan it exactly how we did it, with the extraction, with the guide, and the sleeve. And now the beauty is here. The beauty is synchronizing with the cares. And then when you synchronize with the cares, it gives you an accuracy of the abutment. So now you can connect the two together. You can make an abutment, and then you can plan the tooth and re-import it back in here, and you can see the merger of the base with it. And now you play with the design of the tooth, and then you can export as an STL, and then you can print it. And all you do is you go back to the model, as I showed you before, connect them together, and now you have a screw retained crown. And this is different shape than we did, because this is not at a second stage. This is at the immediate, and this is what Steve Chu has talked tremendously about, that curve. And now we can reconfirm the guide, and then I do an alternative plan B, because we cannot have 100% of placing an implant and immediately loading it. So we do the printing of the models. I give them to the referral, and he did a Maryland kind of a bridge, prepared it for the eventuality that the implant does not get loaded immediately. So we went to the surgery, extraction as a traumatic, and it makes me laugh to a traumatic, because you are ripping something. We are removing the elastic fibers, regardless if you are doing it gently or not. At the end of the day, it is not, and the soft tissue will shrink back a bit, and you will see it. And this is to reconfirm the resorption. But again, I want to ask you to look and appreciate this anatomy of the tooth, this lining between the central, the crown, and the root. Usually you can get them at the 20 degrees, but this is a really, we have to think about it when we are doing the cases. And this is fully guided, not like the case that I did before. It comes prepared or fully guided, so the implant will be placed fully guided. Now, I want you to pay attention. This is the guide. It gives you this notch, and you put the Luxem points to the notch. If you don't, then the fit of the temporary that you made does not fit in. We followed the criteria of 3 millimeter from the gingival margin. And from there, we put the temporary. And this is what I said before, when you extract, it does shrink a bit. But that's okay. Wait a few weeks or a month or so, and then the soft tissue will build up again. And this is to compare what we planned on the model from the printing and to the execution of the case. And that's the radiograph. And I do place it centered with the zenith. And that's a paper that we just published. I don't know what happened here. It went away, but we published it in Inside Dentistry. Moving to a next level of the digital dentistry and execution in surgery. This is a case that was referred to me after a socket was grafted. It failed. And again, it can happen. No fault to the person. They tried their best, but it didn't work. But because they didn't look at the CBCT beforehand. The importance of looking at the CBCT beforehand, because it gives you a lot of things. First of all, talk to you about the apical topography, the buccal plate, combining the STL with it and knowing what kind of a biotype we're dealing, but most importantly, understanding the landmarks. Because here we take it for granted, but I have quite a bit of series of failures of immediate implants because of the closeness of the nasopalatine. So you have to grab the lingual part, but you don't pay attention that the nasopalatine is expanding inside those things. And that's why I'm really big on the CBCT before the extraction. And this is when you look at it on the rendering, it doesn't give you justice until you print it. And when you print the model, then you have a better understanding of what you're dealing with. And look at the nasopalatine, that explains what happened in that case, that it was expanding, and when they did the extraction, that lingual plate did disappear quickly, and the soft tissue of the nasopalatine expanded in and it turned into encapsulation. But here you can communicate with the patient. That's a very important thing. Now you're going to put this patient to a tremendous amount of surgeries, but they don't understand what we're doing. But if you print it and you show it to them, it gives you a better communication with the patient and with your referral, since we are talking to mostly a perio community. So you have to communicate, or even if we have oral surgeon with us in the night, so you can see, you have to communicate with the referral, and then you can show them, look, this is the problem, this is what I want to do, this and that, because when you have based on referral, they came to you, but they do trust the referral. So they're going to go back to them and they're going to tell them, this LCR told me about this thing, but if you have it and you present it to them, everybody is on board. So I'm going to talk to you about this case, and you can do it 3 ways of treatment. You can do the Khoury technique, and I love Fouad. Fouad is my compatriot, is Lebanese like me, but not only that, both of us graduated from St. Joseph University. We have a very dear relationship, but he loves autogenous bone because he is in Germany, and in Germany and Europe, this allograft is a big taboo, and only Xeno. But Germany is better than the rest. They are open to allograft these days. So moving along, you can do it either with autogenous bone, or you can do it with an allograft. In an allograft, you can do it either with non-resorbable barrier, or you can do it with bone ring allograft with simultaneous implant placement. So sure, when you are in residency, and you have to understand, I was trained with autogenous bone. That's the only thing we did back in the days. But, I don't do it much anymore. But, if a resident comes and say, hey, I want to experience it, that's our job, is to open the doors for you, expose you to everything. And this is exactly what I did with the gentleman, Jeffrey Rubinstein. He graduated the class of 2020, and he wanted to do this case. So I did it with him, and this is something that we've all my life did it. And so we take the piezo, we go to the myelohyoidian, you take a block, exactly what they did. But one thing that I want to bring back to attention, yes, it's not the golden standard. There's no golden standard, especially when you go to myelohyoidian and retromolar. This is all avascular bone. I mean, this is what you see here. It's nothing. By the time you scrape it, you end up with cortical bone. So you are doing an osteoconductor in all reality. And even if you scrape that bone from here, and you can see it, everybody publish it on social media and all of these things, you are ending up, it's like you're having a tori. You're taking that bone, and we know the result of a tori bone. It's dead bone. It does not turn into real bone. But regardless, the good thing about using autogenous bone and creating the space, you will have bone. That's no question. But what is the problem? The morbidity. We are opening another site. Secondly, most important is the limitation. And you will see in this case, and you want to do a double plate here, there's not enough. And that's where the beauty of having an allograft, you have an abundance of it. So now we can see we follow the same technique of Fuad. We scrape the ridge, we scrape the inside, you get these things, and it turned to be a good mixture. But now when you slice it, you end up with two shells. And now you go and you decorticate, and there is a jury still out there about the decortication, the need of it or not. So you put the two blocks, and you can see already immediately at that point, you see the limitation. Huh? You have a gap, and you have mainly the lingual that is, you're going to see it here. You place it, you've closed it. So you created a box. That's what we know. That's what I was meaning before about sausage. You need a box. You don't do a round. And then now you fill in the gaps with that bone that you collected, and you can put allograft if you want cortical bone all around it. But this is what I want to bring to your attention. When you are dealing with autogenous bone, you are on your own, free-handed, and this is where things can happen. So you can't plan it accordingly. So this is where the implant will be. And this is, if you put the prosthetically driven the curve, this is where the implant should be. Nothing wrong. You can always do it and you can restore it, but depending on what you want to do. And this is what I wanted to bring to your attention. You go autogenous bone, you're free-handed. You can't control it, and there is a limitation of the amount of bone that you can get versus an allograft, which is this case. So you see here, it's, I don't know how it ended up like this, but it did. And this is what we do is we go to co-diagnostic, we clean it up, and I can print it out. And I like to take multiple images because it gives you the lay of the land. And now what I did is I extracted the tooth, the next door tooth, and I flipped it over. Now, reason I did it because I want to see the volume that I need to create. I want to see the anatomy and prepare myself of how can I fix the down the line. So this is exactly what you see here. The tooth is extracted. Now you can see the volume that we have. And now we can template it. And then I go to my favorite thing, which is the titanium mesh. Now, yes, like they say, all the roads lead to Rome. And you can go to a cytoplast. You can do whatever you want. This is the thing that I do. Now, when I do titanium mesh, I want to bring it carefully. I don't want to mislead anybody. I'm using a medical grade titanium mesh. I am not using any dental of them. And the pore size is a 1.3. This is an osteomed, and today I did in my office, I use Synthes, and I use the screws. The medical screws, they are very expensive. They're not the dental screws. If you want to take the regular screws from dental, good luck with that, because they cannot self-tap. It's very difficult to put them, and you really need a good stability, a good grip. So I wanted to be transparent and tell you what I'm using. And then you passivate the flap exactly how I talked about it. Here I do only slings, and here I do horizontal matrices with interrupted. And I urge you to read the article about titanium mesh. We were very particular in stating step by step what we do. Now look at the difference. So we take the titanium mesh, you have the bone, you place the implant, and you can see the position of the implant. Now, this is the two things that I want to bring to your attention. Yes, definitely we follow the ITI 3 millimeter. We have a guide, the regular guide from not only the guided surgery, I make a guide, the regular one, the SX1 with the final tooth where it should be. I measure from the gingival margin to the implant, and I position my implant centered within the zenith. And now this is what I want you to see, prosthetically driven, meaning following the curve, and look at the amount of bone. This is not a sausage. This is a 90 degrees platform, and you have enough on the lingual and enough on the buccal. And this is the importance of placing the implant and studying it from a model and executing it. So again, this is what I mean by the positioning following the zenith, and that's the paper that we have just came out with it with two of my just recent graduate, Gretchen and Brett. Going back to that case, how did I treat it? Well, this is what I did is I opened the flap exactly how I do it consistently with everything. This is my incisions. And here you can see the opening. Now I did a modification here to the original article, which I do a submarginal from here and I extended them both into the palate. This gives me a potential of better exposure of the palate, because doing cases like this, you really have to expose and go up into the palate. And now I did this, the Stroman ring. Now, this is the classical way that they teach when they do the course. I've changed it, and I'm going to show you how I changed it. But this is the original case that I did with it, and this is the ring that is fitted in the site. You place it, then I put two membranes, one on the buccal, one on the lingual, and I laid inside the cortical bone because this is made of cancellous, and I covered it and definitely passivated the flap and achieved primary closure. This is the implant at time 0. This is at 8 months. This is with the roll technique. You can see this is the cap, that's the holding cap, and you can see how the bone grew over it. And you had to dig the implant to identify it. And then we post back to temporary, send them back to his referral. But let's look at where we started at time 0 and at this is 3 years follow-up. So I have quite a bit of these ring allograft that I've done in my practice and also introduced to the school at NYU. And this is what we came up with right now is we changed the whole protocol and we have submitted the paper. It's in review right now. We are at the second review. Is that this is the guide. We do it from guided placement. So it's the opposite. They do a 2.0 and then they do the trephine and the planator. No, we do it differently. We go all the way to the last burr of the implant placement with the guides. As you can see it here is the 4.1 to the depth and everything. And now this is what we introduced. The problem with this technology is that you take the trephine, and I'm sure the people who are in the audience that had a lot of experience about removing implants using a trephine, which I did today, and once you hit the bone, it slips. And that's the problem with this. So it slips on you, and then the whole thing is moved buccal. So what we did is I came up with this with the help of Ron Roche, who is a great resource that they have at Dental Wings. We've created this guide, that has dual use, one for the trephine, so it controls the trephine from the vibration. And once you do it, this is the second one for the planator. We made those little jig puzzles that you put them inside. And what it is, it holds the planator during the preparation. So when it goes in, it doesn't move on you. And now you use it this way. And this has increased the accuracy of the placement of the implant with the ring versus coming the ring coming a little bit more buccal oriented. So moving along to my last two parts of this and of this presentation, this is a deficient ridge that this is one of my assistants at that time. She had a failure of a molar, and on top of it, she had this ridge deficient here. So this is the cone beam. It can show you exactly that area, how deficient it is. And definitely, if you look at it from one view, it doesn't give it justice until you see it on a model. This is the model. You can see now very vividly the defect that we're dealing with. So what I did is I sent to a lab, it's LifeNet Health through Stroman. They do the milling of a 3D allograft bone block. And this is the design that they make it for you, and then they send it to you for approval. And once you approve it, they mill it. It takes up to 45 days to do it. So in this case, I started first by extracting the tooth, debriding the socket, let the soft tissue heal. And you can see the difficulty here. We were very close to the adjacent tooth. We took it, we let the soft tissue heal 6 to 8 weeks. And now we go ahead and we do it. So we place the graft, the 3D printed one. It really snags in place, and you stabilize it with 2 screws. It is an allograft cancellous. It's not a cortical. It's done from the femur, head of the femur. And that's why they end up with a cancellous What I do is I add on it a cortical bone. So I layer here, we layered also, we did cancellous, cortical, and on top of all of that, I did cortical. And this is a resorbable Stroman flex. And this is the passivation, as I showed you earlier, of the flap. And I do horizontal mattress plus sling suture plus interrupt. This is at time 0, and that's at 8 months. With allograft, I do wait up to 8 months, not 6 months. And you just can appreciate, go back to here, you can see the height that we achieved, and here also the width that we achieved. So now we go ahead, and this is the visual of the case. You can see the amount of bone. The reason you can appreciate it, look at the tacks, that they are literally engulfed with this amount of bone that has grown horizontally. And now we place the 2 4.8, and we put her on temporary. Unfortunately, she broke her ankle, and this is a 2-year follow-up. But again, I want you to appreciate the stability of the bone, the crestal bone, and something that people like to talk about all the time is the allograft stable on the coronal part. Well, it is, and I've showed you over and over multiple cases. So brings me to the last case of today, and this is a literally very challenging case because it is an anterior. It has so many things against us. Daryl is a lovely young man. He was referred to me by a neurosurgeon and to take care of the anterior area. And when you look at it, and you can see the problems that we have. Now, he lost his teeth, but he didn't know that he had periodontal disease. That's the sad part is, this young man is going along in his life and he had no idea he had periodontal disease. And you can see also the flaring of the central, the canine, and the deficiency of this ridge that took place due to the flaring of the central and the lateral and the exfoliation, basically. And one can appreciate the edema and the erythematous tissue on the canine. We look at the radiograph, you can see he has typical molar and incisors pattern, and a little bit here on the premolars, but I graded with an incisor pattern grade C, and because of his age, and stage 3. So from there, you can take the scan. The scan will not tell you the whole story unless you print it. And once you print it, you can appreciate the amount of destruction that we are facing. And most importantly, at this periodontal defect that you cannot see on a regular radiograph nor on a cone beam. So this is the amount of loss in vertical. And this is just to give you, as a periodontist, we can't live without a probe. And now I prepare my case, I put the wax, I prepare exactly what I wanted. I trim my titanium mesh. This is a different brand. This is a Synthes, the same pore size. This is an Osteomed. Both of them are medical grades that they use for suborbital or for maxillofacial, for the mandible, for fracture corrections. And you can see this is the incision consistent in my procedure. Now, when you open flaps like this, as I showed in the other one, as I will show you here, is the removal of the nasopalatine. There's no fear of it. So you have to elevate it. You don't jump into it and immediately take it, but nevertheless, you dilate the soft tissue all around it, it extend it out, and then it becomes very thin, and then you can snap it. Or you can leave it if you want. But you don't get any loss of sensation in paresthesia, nor you're going to get an uncontrollable bleeding as they scare us all along. And this is not one case. I have multiple cases. I'm doing the same. And so here, comparatively, between the model and the accuracy of the 3D printing and with the real life, now I prepare my titanium mesh. This is how I do it. I already trimmed it. I secure the cage on the lingual, first of all. So I placed it there, and then I layer my bone. So this is the cancellous. Then I put a layer of cortical here. Exactly what we described in the article. Then you continue the filling up of the graft, and then you flip it over, and then you secure it from the anterior. Now you can see how you can control the width, not only buccal, but mainly lingual. Because here in this case, in this particular case, or the other case that I showed you before, the importance of building lingual bone is primordial, is more important than doing it only on the buccal. And now you can see and here I didn't want to put another titanium mesh. I just put a regular membrane because the space is maintained, and this is more of a socket. And again, primary closure, stretching the flap, no vertical incision whatsoever. I love to take immediate post-op CBCT, and this is at 8 months post-op. And this is, I can compare from time 0 to 8 months if I had shrinkage, how much shrinkage I did, or I was successful. Now I move to the next level, STL taken, and now I go to co-diagnostic, and you can see with co-diagnostic, you can clean it, meaning I can separate the teeth from the bone, I can remove the scatter, and this is important because now you're going to stitch, you're going to take one point to another point, and they tell you 3 points. In reality, you don't. You have to take multiple points, but in order for you to put the point properly, look at the scatter that you have on the tooth. It's not going to be fitting properly because now you're going to put this on an extra layer that was done on the tooth, because in reality, the tooth does not have this double layer. And that's why it is so important to use a real well thought of softwares. The planning of the implant, and definitely I plan the central and the canine deeper than the lateral. And now this is the 3 of them. And now from there, I control my positioning, and I look at my guide, where it is and how deep it is. And you can see the lateral, we put it on a little bit higher. And we go ahead and we remove the titanium mesh, and now you can appreciate the bone, especially here, if you remember the amount of bone that we were able to grow in a vertical manner. And this is comparatively between the before and after to show you the amount of bone regeneration. Definitely on that case, I don't have histology, but you want to see something like this, a lot of bleeding, a living bone, and well-rounded and well squared up on the coronal part. And now you put your guide, and this is the 3 of them. Those are 2 fully guided, and this is a pilot drive. It's actually for the final of that diameter. And sure enough, the placement, you can see the difference in levels. Do it on purpose because the central is deeper or much apical than the lateral. And this is the immediately post-op radiograph. And this is at 4 months later. Here we had a little bit of recession on the central, and that's when we take care of it at the time of the second stage. Now, also, you have to work on the soft tissue because you've hiked everything down. And it's very important in this case. The challenge in this case is that he is African American and he has this melanin pigmentation. And that's something you have to be very careful, because when you are doing cases like this and they have a lot of pigmentation, you have to discuss with the patient that why we are coronally advancing, we might change this pigmentation, especially if you want to do a roll technique or you want to play with the position of the flap. It's very important to keep that in mind and discuss it with the patient before you go into the surgery, because you can end up with a patches of white tissue within a sea of melanin pigmentation. Now, this is how I did the flap here. I did not do any vertical here. I took a fibro guide and I snug it under, as you can see here, and I coronally repositioned the centrals with a, I call it the Vista, is a sling that I do. Hopefully one day I get it published and you can talk about it. Not the Vista from my friend Zadeh, but Vista. It's just a joke with him about it. And then this is the pedicle papilla that I take from the palate and I rotate it, and you do a horizontal mattress in here. And now we go beforehand, before we did all of this case, we immediately went to the synchronizing the placement of the implant with the CARE software. And doing that allows us to basically design the temporaries and attachment to the real position of the implant. And you can see the synchronization. This is the abutment that is recognized between the two together. And from there, when you are designing, you can play with the profile, you can do the subcritical, critical, whatever you want, because you know where the soft tissue is. This is the soft tissue that you're making, and then you can play with the emergence profile. And now you export this as an STL and you printed them. And definitely they need a nice touch. And this is by Dr. Farahani, did an amazing work. on embellishing this resin printed temporary and made them more aesthetically appealing. And he fit them in the mouth time of the procedure, and we let the soft tissue mature around them. And sure enough, when everything matures, we can move forward for the final part. But this is a layout of the temporaries, and now he let the soft tissue mature. You can see the maturity, the thickness, the width, the position of the melanin pigmentation within the rest. And he moved along, and he's finished the case that we had the pandemic. Couldn't recall the patient now, but you have also a temporary veneers on the right side as well as on the left side. With that, I like to end the presentation with what I call charisms. It's taken from my last name, and from there, this is where we came from. I mean, this is how they discovered the west of this beautiful land called United States. And this is the caravans that went to discover California and Arizona. And then from there, they built the trains. And the trains was a huge technology improvement. So from caravan to trains, and to finally to my favorite, which is the Airbus A380. And I can tell you how much I miss flying these days. And this is the where we were. This is how we travel to where we are today. And that's why we need to really open our horizon when we do surgery, that there is a lot of technologies that can come about, that we can use them and improve our predictability and our outcomes. And with this, I like to end it with this saying from Yogi Berra. I am not a baseball guy. I have zero understanding or love to the baseball, nothing. No offense to anybody. I apologize if I offended anybody. But Yogi Berra is somebody that I followed his sayings. And this is barely had a high school. He's from New York, played for the Yankees, obviously. And he just passed away 5 years ago. And he had a lot of quotes. He was famous for his quotes. And one of his quotes, I loved it. It fits to this subject. I always thought things would stay the same until they changed. And with that, I want to thank you. I want to thank Rodrigo for inviting me to his series, and to be with you at Japan. It's always been a great place to be with, and I'm open for you for any questions.
Thank you so much, Dr. El-Char. It's always such a pleasure listening and learning from you in real life and now in the virtual world. Such an amazing presentation, so many topics, where to start from. So I'm gonna start with some of the audience questions and then a couple of my own. There are some questions regarding the stretching of the flap that you demonstrated. Could you elaborate on that a little bit, and how so the question is from Zakaria Atia. Can you explain how you do the stretching passively?
The stretch, what?
If I understand the question correctly, is how you achieve passive closure.
Okay, good. So there is two things. The flap, as I showed, the flap is made of two parts. You have the keratinized area, and then you have the mucogingival line, and you have the alveolar mucosa. The mucosa, it's a bed of elastic fibers. So if you take the instrument and look at my hand, you can see me, right? Okay, so you pass the mucogingival, you take a blunt instrument. I recommend to use the Buser instrument. You take the end part of it, and you just push out and down. And by doing that, you're really basically dilating those elastic fibers. Now, if you had, very careful, if you had surgery done before, be it an extraction and you let the soft tissue heal, now you're going to have a fibrosis on the inner layer of the flap. Now, this is where it becomes tricky. You cannot dilate, you cannot stretch, because it's all really scarry. And instead of taking the blade, as we all learned, take the blade and cutting it, in the opposite, this is the flap, you take the blade parallel and you remove the inner layer. So by removing that inner layer, basically you're removing the fibrosis, that scarry tissue that is inhibiting the movement, and immediately the flap will mobilize. Then you go back to the blunt instruments and you do it. And it is really very feasible. And one thing I want to tell you that's very dear to my heart is that if a technique only works in one person's hands, not with everybody, then there is a problem. And we've seen it over and over. But when the beauty of, being in academia, and like my friend Rodrigo will vouch for that, is when you have a resident that can be able to do the same thing that you are doing, that means it's a feasible procedure and it's reproducible. We've seen it, we've seen this, I don't know what they do and whatever. At the end of the day, they're cutting into the flap, and that's what you want to avoid. The more integrity of the flap you keep, the more it is better for the outcome. And you can read the article that I published, both of them, the titanium mesh and the other one, and it details more the technique and the thinking behind it.
Thank you. And there is a second question again regarding flaps from my co-resident, Dr. Chen. If you can explain more about the palatal flap at the second stage on the last case you showed us.
The last case palatal flap. What do you mean by the last case palatal flap? Can you see my screen, or we are not anymore?
Not anymore.
Okay, so this is when talking about the second stage, when I did the second stage.
Mm-hmm.
Okay.
Yeah.
Oh, you're meaning about that pedicle papilla. Yeah. Yeah. The pedicle papilla. The pedicle papilla is, if we go back, because, Rodrigo and I, we trained the same time almost. So back in the days, you will know the name very well. There was a gentleman by the name Palacci, who comes from Marseille. He wrote a book with Brannemark. He did the rotated pedicle of the papilla from the buccal. So he took a semilunar incision at the coronal part, and he took that tissue and he rotated it, and he did an H shape without connecting it to the palate. Now, when you do these things and you start seeing a complete necrosis of that pseudopapilla. Now, what it is important is that when you extend this flap, you're going to have bone exposed in between. Now, if you want to have nothing and you let the soft tissue repopulate that space, it's going to be with a curve. You're never going to have a flat. You're never going to build around implants a complete dome of papilla, but you want to have at least a flat that you can work with, and with the beautiful work of the prosthodontist or the prosthetic, they can do a little bit of a pseudopapilla. So you want to start with something. And if you do it from the buccal, as Palacci showed, unfortunately, you get a lot of necrosis. So what I did is, you always, when you do something, it fails, you blame yourself first, you do it over and over, and it's still failing. There's something wrong. So I looked at it, I said, okay, so I have an abundance of soft tissue on the palate when I do my incision. So instead of cutting it off and throwing it out, why don't I take an incision, and I flip it over? It's literally, you take this band of tissue, it's tons of it, you flip it over. Now, if you leave that soft tissue, you're going to end up with a pocket, pseudo pocket around the implant. So if you take that soft tissue, it's still pediculated, so the blood supply is in it, you lift it, you just transport it. Now, what I did addition is, from the buccal flap, I did a horizontal mattress. So I go from the buccal, I grab the under of that papilla, come up, grab it from outside, and come from next to where I entered. So you pull it, it becomes everted. So you'll have the inner part of the flap with the inner part of that pseudopapilla that you turn. And this is what I did. I do that systematically. It doesn't take much. It's not that complicated. Trust me, anybody can do it. And it's very predictable instead of leaving that space empty.
Thank you. And I also have a question of my own before I pass it on to my co-resident. So since you're speaking to an audience of much less experienced clinicians, mainly residents, I wanted to ask you about complications and how you manage them. For example, you showed us those beautiful GBR cases, either with the ring or with the time mesh. So of course, we try to do everything ideally and have passivity of the flap, but sometimes we do see incision line openings. So what's your input on that?
Absolutely. Thank you. This is actually, I was hoping somebody would ask me that, because, if anybody tells you I've never had a failure, that means they are liars. And so we learned from mistakes. I mean, it took me a long time to achieve this predictability over and over. First of all, I don't do a membrane under the flap, between the titanium mesh and the flap. And that's, in my opinion, was when we did the cases, the ones that I used with membrane, I always had a early opening. When you get an early opening with the titanium mesh, it is different than the cytoplast. This is where people get confused between both. You have to monitor them, definitely, and you show them how to keep it clean. Within a week and two, everything will settle. This does not happen with the cytoplast. Once the cytoplast gets exposed, then the risk of infection drastically increases. With the titanium mesh, once you cross the first 2 weeks, if you had an early exposure, meaning the first week, usually those exposure happen, guess when? 4 weeks, 5 weeks, 8 weeks, and even 3-4 months. The soft tissue becomes too thin over them. And that's why removing those titanium mesh becomes more of a headache. But that's fine. You let them heal and you can augment soft tissue. That's what we have to discuss with the patient. But the predictability of creating a space with them and reduction of infection versus the cytoplast, it's drastic. Now, where you get those infections with the titanium mesh is when you use the dental grade, meaning the one that you buy from dental suppliers, because they like them flexible. It's actually the opposite. The problem with the cytoplast, and you've seen it over and over, the reason it exposes two things. The titanium reinforcement in it is very thin. So when you put it and you put pressure on it, it flexes. It's not rigid. So the flexibility with having the surface that it doesn't allow the soft tissue to adhere to it, it opens up. They are coming up with a new cytoplast now that is a rugged surface, believe it or not, with micropores. The opposite than the first. And reason is because people like myself, I showed it with titanium mesh, it works. So with the titanium mesh, the soft tissue adhere to it. Now in the layering, I use the cortical layer on the top. Using the cortical layer in the top is inhibiting the downgrowth of the soft tissue inward because it acts as a barrier actually. So this is the thing, and in titanium mesh, the exposure is not the problem. At the beginning, you have to be not fearful, but you have to monitor them carefully and show them how to clean it. With the cytoplast, is a totally different ballgame. I'm not bad-mouthing cytoplast. I'm not saying anything bad about anything. I'm just sharing with you the differences, because I've done it with cytoplast many times, and I've had a lot of infections.
Thank you.
And just in parentheses on that, my dear friend Ronda from Italy, if you notice what he does with the cytoplast, he puts implants underneath them. So literally the implants are acting as a tenting screw. So the flexibility of the cytoplast is inhibited by the implants versus the Urban only works in his hands anyhow. So that's a different game.
Thank you so much. And with that, I will pass it on to my co-resident, Dr. Mizorian.
Thank you
Hi,
so
Taline.
much, Chef. Wonderful presentation as always. Thank you. Thank you so much for being here today. I have one question of mine, and I'm going to read questions about the audience. So you said you combine cortical and cancellous bone, right?
Mm-hmm. Correct.
So what is the proportion of each one? Do you use 50-50 or is different protocol when you are grafting sites with bone type 1 and type 4, for example?
Yeah, a 50-50 is very hard to do it when you're layering it on your own. You buy it pre-made, then it's done. What I focus first is I layer the cancellous on the bone. So regardless of how much it takes, so I cannot measure it for you quantitatively. But the most important is I use the principle of using the two. One is delayed resorption. One is an early resorption. Now, why do I need the two? Because we know that the blood comes from the walls and the bone comes from the walls. So if you put a cortical bone, it dries it up. So then it inhibits the movement of the bone inside. So you want to have the housing coming in. So that's why I use the cancellous. Now the cortical bone, I use it more on the outer layer as a barrier, basically, just to create a less resorption, less invagination of the soft tissue into the graft. And that's what that's how we discover, that's what I've been able to prove. Now, again, I've studied these things in private, then bring them to do them with the students, and you can see the replication of the same over and over, and that's how it works. Now, I cannot tell you half, doesn't work this way. It's just depending on the topography and how much it takes.
Thank you so much. I have another question from one of my co-residents. She's asking about the case of number 9 with no buccal plate at the time of the extraction. So did you use a membrane before rotating the pedicle connective tissue graft?
No, great questions. No, exactly my point. That's what I was telling you. Since using the titanium mesh with no membrane, with pores, and I was achieving a great results with it, I've pushed my envelope further. So I have this flap. The space is contained, so I am not immobilizing a flap. So when I layered my cancellous and the cortical, and I put the cortical towards the buccal, towards the flap, I have not had the need to put a membrane. And definitely, I've done everything. Don't forget, I was trained when Tarno was in our school. So we talked about the ice cone technique, right? Well, it didn't work with me very well. The reason is because when you put a membrane inside, you're inhibiting blood supply, and that's what's the most important. So in the principles of bone regeneration is the containment, space, that they are very important, and the stabilization. So if you achieve them with layering with the allograft. Now, if you do that with the xeno, then you have a failure, because the soft tissue will invaginate, because the blood supply does not fall into it the same way it falls with the allograft with layering. And that's why it is so important. I think Rodrigo shares with me the same passion about allograft. This is how we became friends, and that's the whole purpose of that.
Thank you so much. I have the last question from the audience. What is the software that you have been used?
The what? Sorry.
The software.
The software, the co-diagnostic. Co-diagnostic used to be owned by Straumann. They spun it out. They have a dental wing. They have still half of their shares with them. It is an unbelievable system. I integrated it in our program at NYU, and they were kind enough to give us a grant. And we have the same printer I have in my office that I showed. We have a smaller one, P20. So everything is integrated. So the care system software for the design, the prosthetic, is Straumann 100%. The other one is called Dental Wings, but actually I think it has a part of the co-diagnostic. It's called co-diagnostic. So it's not that complicated at the beginning, but you can learn it very quickly. If you guys want to learn more about it, I'm more than happy. Rodrigo is a very dear friend. I can share with you a lot of things about it, because I like to share what we do. It's not like I don't like to keep them inside. And I love these things because I started working with co-diagnostic. It used to be version 8, 2010. We used to mill them. It's like a miller, like the surveyor. And it was a nightmare. It didn't work out. But the software is amazing. And the most important thing in the software, it lines up the image of the crosscut with the long axis of the implant automatically. So that's a very important thing. And then it turns the image all around the implant. So if you are in a doubt apically and stuff, you can see at 360. So it has a lot of advantages. And the most important thing is the segmentation. And the reason I say it is important because we know that there is a scatter. I mean, I don't know whoever took a scan that does not encounter the scatter. If you have crowns in your mouth, you have scatter. You have a lot of PFMs, you have tons of scatter. The question is, how can you clean the scatter? And that's what it gives you. It gives you like a Photoshop. It takes the skull and it divided it in sections. So you can take the teeth off of the skull. You can clean the skull off and then clean the teeth back, and you put them together. And then you can stitch the two images together. There's a lot of things outside. There's the Blue Sky Bio. There's too many of things. I'm a big believer, anything for free is for free. It lacks. Co-diagnostic is expensive, but it gets the good results. And I don't get any loyalty anything from them. It's just something I was passionate about for many years, and I enjoy it. Oh yeah.
Thank you so much.
Thank you. Thank you for having me. I really appreciate it. I didn't want to keep you too long. I kept my time exactly a little bit lesser, but it's late. I don't want to overdo my invitation.
No way, that was fantastic, Ed. But I love your presentation because you took us from your learning experiences, and I think you and I have a lot in common. And I think there's a reason why we do the things that we do, and it's because we have done things in a different way in the past, and there's a reason why we don't do them anymore. And you and I have talked about this before. We're kind of surprised when we saw this wave of like xenograft that people start doing because of heavy marketing that came from the industry, forcing European speakers to show the crazy stuff that they do in Eastern Europe, but it only works in Eastern Europe.
Correct.
And everything amazing. And then we, as educators, we have a hard time convincing our residents that that's not the best way to do things, because we've been there, we've done that, we have seen things, over time, and we have also had to deal with the complications of former residents that have tried that too. So, and the truth is that having talked, off the record with a lot of these presenters from Europe, they all agree that if they had access to the stuff that we have, they would use what we use. But 100%. They're stuck with xenograph because that's all they have. But I absolutely love your presentation and rationale for doing things. And you show the things that we have done, and what we're doing nowadays, flying the A380. But there's really no way we can do the things that we do nowadays without the technology that we have nowadays. So the whole planning, before it was a big guessing game. Now there's a lot of planning before everything that is done. How many times have I done like a large augmentation procedure and then went back in and realized that I really didn't need to do, because the implant position would have been okay with the region where it was before. It was just like really, we were always working like backwards in the past. So my question to you, Ed, is this. We know where we are nowadays with the technology that we have, combining digital dentistry with ridge development and implant placement. But my question to you is this: where do you think the future is? If you had like a, how do you imagine that we'll be doing things, 5-10 years from now? I know it's really hard to predict anything, because we would have never guessed we would be where we are today, right? With all this crazy softwares that we have, and in 3D printing being like a common thing in your office. It's just like we never imagined that we would be where we are nowadays. But where do you think we're going to be like 5-10 years from now?
Yeah, I'm glad that you asked me that question, because it's funny. There is a new things that coming that they are doing now, titanium mesh, pre-made, pre-designed per request, pre-tailored. And it's funny, it's coming from Europe, and they are making them in a way that you have a hole that you can place an implant in them. Find it ridiculous, because at the end of the day, if you don't remove that titanium mesh, you are increasing your risk with peri-implantitis to have something more even worse. So I think the more tailored treatment is the future to come. So, all the steps that I'm doing, and it takes time, it takes hours. I'm not going to lie to you. It's not like a 1, 2, 3 to do a print. Because sometimes you wait an hour and a half and it doesn't print on you, and you start screaming bloody murder that it didn't print and why. And, technology is beautiful, but sometimes it doesn't work. So I think what we are heading is exactly how I showed that 3D printed or 3D milled graft. We're going to see 3D milled titanium mesh to the demand. So tailoring bone grafting is going to be the future. at this point, the prices are inhibitive. This case that I did in my office for the 3D printed, I did 2 of them. Well, the second one, it was through the pandemic, so I didn't get to see the results yet. So it's too early. But the other one that I did on my assistant is the block cost $1,800. It's $1,800. So it adds to the bill basically, plus the screws, plus the tacks, plus the membrane, blah blah blah. But if this can be more predictable, if we get to a point that we can tailor this material, it cuts down on the work time tremendously. And if we can cut down the price of it, that would be great. So I think it's the tailor treatment. That's what we're going to be seeing coming. And you and I will remember the J block. Remember the J block? Yeah. That was a failure. Yeah. But nevertheless, because it was too early, we did not understand the biology very well. And you can see the new blocks are coming completely different, all cancellous. No more of a cortical on it. And it was a lot of work, as you remember, there's a lot of cutting and milling and all of that. And you put it and it fails on you. And then you say, oh my God, what did I do? Now it's more predictable, obviously, and it's more tailored. So we don't have to do all of this work. And that's what I see it. I hope I'm right. We'll see. We'll see with time.
Like you showed, I think that most of I happen to have had good experiences with J blocks, but only in the pure maxilla. Every one that I tried in the mandible failed. Every single one of them. Yeah. Pure maxilla, a lot more forgiving. But I think that is true for J blocks and is also true for autogenous blocks. I think the failure started at the surgery, based on how long it took you to shape that into the ideal shape. How long that block was in your hands, and sometimes it would fly and on the floor. And I think that the majority of the failures ended up happening that way. So I think like 3D printing and CAD/CAM milled blocks and is definitely the way to go, because we can't replace natural tissues. I'm like, if you have the capacity to get like an allograft and transform that into like a Lego piece that will fit precisely, we know that the body knows how to do the rest. So I think that to me seems to be the most natural or the most predictable way to go in the near future. Maybe 10, 15 years from now, there will be some other technologies that will be able to print the whole tissue, in the lab, but we're too far from that.
You will be retired by then.
Hopefully. But then this kid will have fun with that.
Yeah. Good. Alrighty. Well,
thank you, Ed. It was great to have you.
Thank you.
Night. Please let us know. It's good to be closer to you now because we can do more stuff together.
Correct. Yes.
The door. Always welcome, my friend. Thank you.
Yeah. Thank you. And I want to tell all the residents that I really missed you this year. We missed the parties at the end in the middle of the tri-school, and the agony of waking up on Saturday after a long night of going out. So it's something that I look for. I did it for 27 years, the tri-school, so it's very meaningful for me. And I miss you, and I hope to see you soon. And Rodrigo, as you know, is a good friend, and definitely Joe and they became close friends also over the years. And I would love to continue that relationship and grow it even further. And if anybody needs anything about the co-diagnostic, Rodrigo, or anything, more than happy to help you with it. I mean, you Penn and NYU, I think, are two families. So yeah. All right.
Thank you, Ed.
Okay. Thank you.
We're going to have a virtual NACE this year here at Penn, right? Because we're going to do
the NEIS. Yeah.
Very good.
Alrighty. Okay. Thank you. And
thank you.
Goodbye all.
Stay safe.
Thanks. You too. Ciao.